In this video, we are going to see the basic steps of an arthroscopic rotator cuff repair. After doing a diagnostic round in the joint, we directly come to the subacromial space to assess the tear geometry of the cuff. Here, as we can see, the superior portion of the cuff is slightly less mobile than the posterior part, and it is a laminated kind of a tear where the inferior part of the lamination is actually the capsular layer of the cuff. So here we are dealing with a crescent shaped laminated tear. For the acromoplasty, I have just removed the anterolateral subacromial spur and a bit of soft tissue acromoplasty. Aggressive subacromial decompression is not required here. The capsular layer of the cuff was less mobile and was not reaching the tuberosity easily. So we went ahead and released the capsule from the glenoid with the help of an underwater cautery. Posterior-superiorly, the release can be done with the help of a liberator by passing it just above the biceps tendon, but one needs to be careful here as we cannot go beyond 1.5 centimeters to avoid injuring the suprascapular nerve. After the inferior releases are complete, we come to the superior surface. Here with a shaver we have to clear out the adhesions posterior-superiorly. Here the adhesions are most thick, so we need to do an aggressive release here. Now we can see the reducibility has improved. The cuff is usually coming to the tuberosity, and we can now proceed with preparation of the tuberosity and our repair. Just like a subacromial spur, in chronic cases there is always a bump on the tuberosity which needs to be flattened out before proceeding with repair, otherwise it will lead again with impingement and re-tear chances are quite high. After preparation of the tuberosity, the approximate position of the anchor is chosen with the help of a needle, and then we proceed with inserting the anchor. In this case, I am planning a double anchor single row repair. My preferred choice of anchor is a titanium anchor which has good purchase even in osteoporotic bones. Here we tap the anchor initially and then start threading the anchor to till the laser mark. We can slightly go beyond the laser mark also if we feel the purchase is not that good to prevent pull out. Once the anchor is inserted, we should give a nice tug to the threads arising from the anchor to check for the back out strength of the anchor. Here I am using a suture passing device to take bites in the cuff. The cuff is repaired from anterior to posterior. The suture which is to be used for taking the bite is kept in the 8 mm cannula, whilst all other sutures arising from the anchor are parked in the posterior portal and shuttled one by one when need arises to take the other bite. After finishing with the anterior anchor, we insert the posterior anchor and proceed with the repair of the posterior part of the cuff. Here we need to be careful to include the lower laminated layer in the repair, otherwise the repair would fail because the superior layer is not that strong enough. We can see here the bite is coming through both the layers. Similarly, the other bites are completed right up till the posterior most margin of the cuff, and we proceed with the knot tying. I start tying the knot from anterior to posterior by retrieving sutures one by one into the 8 mm cannula. I prefer using a SMC knot, which is a sliding locking knot, which prevents slippage of the first knot while tying subsequent half hitches, therefore preventing the loss of tension in the repair. After initial setting, I push the knot on the cuff as much as possible to achieve good compression of the cuff to the tuberosity, and I lock the knot with past pointing on the post limb and pulling the loop limb. Similarly, all other sutures are tied from anterior to posterior, and here we can see the cuff is nicely sitting on the tuberosity. I have used a simple suture configuration as this gives good results in a simple non-retracted cuff tear. Thank you for watching the video.